We've got our panel, and we've got a quorum. I don't think I need this. I have not received instruction about how much time, so I'm going to be a little. How much time do you each of you?
10 minutes.
10 minutes, 8 to 10.
8 to
Yeah.
8 to 10. All
8
right.
to 10.
Yeah, I think we can
That's the instructions we were given.
move through that. And as has been the pattern, I'm going to ask each speaker to introduce themselves when I think. But as you know, this session is on oral and cervical cancer and HPV. And I'm curious as to why I was called from New York to do this session and so forth. But I have personally a couple of things. More than an intimate relationship with the whole cancer business. I'm the oldest son, oldest of 7 brothers, all of whom have been treated for prostate cancer. And one brother, we lost a brother. Last year I lost my son to pancreatic cancer. So I've been around cancer for a little bit. In addition, my personal career, since we're introducing, I've been retired from clinical practice for a long time. I was head of dentistry for New York, head of planning and program development also for New York. Actually, I headed up Jimmy Carter's healthcare when he was running for president, his healthcare committee, and discovered then that he didn't know anything about healthcare, and I didn't know enough. So his healthcare never got implemented. And I've been all over the place doing a lot of things. I describe myself as a professional dilettante, but except for one thing. When I get involved in projects, I expect conclusions and positive outcomes, and I've been pretty successful in doing that, building hospitals, international programs, and that sort of thing. Enough about me. Let's do this in the order of the program. And as they did this morning, I'd like you to introduce yourselves to the extent that you would like to within the 10 minutes. We'll do 10 minutes instead of 8. If you need 2 minutes to introduce yourself, then 8 minutes to present. We can go that way. And Dr. Fletcher, you're up first.
Okay, that's fine. My name is Nathan Fletcher. I'm the dental director for AmeriHealth Caritas, District of Columbia, which is a Medicaid insurance company here in the district. I'm responsible for managing the dental network of providers, maintaining a certain level, certainly to meet the requirements set out by CMS for Medicaid programs. This as of May will be my 30th year, having graduated from Howard University's College of Dentistry. I graduated from Morgan State University with a bachelor's degree in chemistry. I also did some work with Ford Motor Company in chemical research prior to going to dental school. I'm a past president of the National Dental Association, which is the premier association for African American dentists in the world. I've worked in private practice, corrections, nursing home, volunteering, and many capacities in care delivery. I've also, as part of the National Dental Association, I was at one point the interim executive director. So I've been also involved with healthcare policy. I have a license in the state of Maryland and D.C. and a private practice in Maryland. And I also testify before the state legislature and the House and the Senate. So the healthcare policy, I actually represented the NDA to Obama's health transition team. So I have those kinds of skills to bring to bear. I guess you want me to go straight into it? Or,
yes.
Okay, so what I'm going to do, I have quick slides, and I'm going to be real quick with the slides, and I'm going to stand up so that I can see them as I present them to you. Last year, I also was a presenter here, and this is really kind of a little bit of an expansion on what I talked about last year. And so last year, I talked about the incidence of oral cancer. Again, I'm going to run through these pretty quick, and I'm going to highlight one particular slide, which is most relevant to the topic we have today. You can go to the next one. And so there are many different types, and again, we can make this presentation available to you at some later time. But there are different types that are there. You can go to the next. And go into risk factors, gender and the prevalence and based upon gender as well as age. Next slide. And some of the factors, of course, are the lifestyle. Most of the time you understand that alcohol and tobacco is usually what is associated with oral cancer, but last year we really started talking about HPV. You heard during lunch part of the discussion, the lady right here, I think you gave the presentation, right? So I believe she said there was 35% were cervical cancer, but I believe there was oral cancer was about another 35%. So the prevalence this year, or 2016, was the first time that the prevalence of HPV is related to cancer for men surpassed the cancer for females. So we are in a new era of discovery and emphasis. You know how it is sometimes when things become prevalent, just like the opioid epidemic. It's not new. It just happens to have a new emphasis. So we now are looking at HPV and how that's related. One of the reasons that it is of great concern is because it's very hard to detect. The other cancers that you'll see, the squamous cells and the others, they will have fairly recognizable lesions, at least to the professional eye. You know, they won't be to the layperson's eyes. You can go to the next slide. And so I really wanted to kind of highlight this slide in particular, the high-risk strains. They were pointed out again at lunch, 16, 18, 31, and 45. Those in particular are of high virulence. 16 and 18 are known to cause up to 95% of cervical cancers. Now these two are also linked to oral cancer. The HPV version 16 has been shown to be sexually transmitted and is really one that is found to be prevalent in young people. The prevalence of HPV is affecting younger individuals. It used to be you looked at 45 or 50 and older. Now we have to be sure that we are taking care of teenagers and young, I guess, post-teen, if you want to call it that, and be more vigilant in addressing that. The vaccine, of course, is the reason that we want to make sure that young people get that early, because again, when you have the issue of early detection being a serious problem, you want to do all that you can of a preventive nature. You can go to the next slide for me. And so these are the many symptoms that you'll see there, and they can be varied. They're so broad, and it doesn't mean because you have one of these that you've got cancer, obviously, but if you have this and any of these things persist over a unexpectedly long period of time, you do want to certainly do a differential diagnosis. You can go to the next one. And so there are different types of screening processes. There's the obvious physical, intro, and extraoral palpation type of examinations, exfoliative cytology, which is using a brush as a brush biopsy, oral CDX, the fluorescing screenings, which is the new light that you shine on the tissues and will give you somewhat of a differential. Live cells will fluoresce, dead cells do not. And there are times when they go through these things, the demonstration of what it looks like certainly is more of a detection, early detection aid than it is just for your naked eye and a light. You have the others, endoscopy. Endoscopy in particular is most relevant to the oral pharyngeal cancer because of the location of it essentially behind the roof of the mouth. It's very hard, of course, and then the others that you have. Next slide. And these are the types of treatment that you can expect to come from that. In the case of oral cancer, it's generally very devastating. You'll have major resection, loss of bone, and you'll have to take a bone sometimes from the leg to reconstruct the mouth. Many hundreds of thousands of dollars, obviously life-changing. And you know, the expense, and we talked about earlier about the trauma to psychiatrically, physically, the family, and all the people who surround. Next one. And so we also can talk about the research and the clinical trials, the issues of which particular strain of HPV and how we can address those issues is of great concern. Next one. And so our key, of course, the key message today is early detection. See your dentist twice a year on that. And I'll wrap up quickly is that with AmeriHealth, because of the discussion I had last year, I have the opportunity to do some innovative projects in the District of Columbia. District of Columbia's incidence of oral cancer is in the top 8 in the nation for African American males. In the District of Columbia, it is the highest in the nation at over 20 per 100,000. It's the highest of all in the District of Columbia. So being in the District of Columbia, AmeriHealth, under my guidance, we have instituted an oral cancer pilot screening. We identified and used those technologies, and we obtained some from the vendors to give to six providers in the District of Columbia, and we incentivized them by paying them for procedures really that are normally covered under their insurance, the routine screening and the technology screening. And so we've encouraged those 6 providers to use these on all patients, not just AmeriHealth patients, but all of their patients, because if we can save any one life and save the cost, you know, there's always a cost benefit to an insurance company, but to the lives of others, of course, we also want to have that effect in our community. So we're looking forward. We've only been in that pilot for about 3 months, and we did it as a 6-month pilot, and we're going to see what happens there, and very most likely we will extend it, because oftentimes the incidence, even though it may sound large, it's not really that big. So we're not necessarily expecting to do some early detection, and obviously we hope we really don't find it, but we do want to find it. That sounds crazy, but that's a fact. You know, we do want to find it, but we hope we don't ever find it. So thank you very much.
Thank you, Dr. Bletchley. What I'd like to do is hold any questions until all the speakers have completed their presentations. And then we can, pardon me. Dr. Swola, founder and president of Mercy International Medical Missions / Community Dentistry in Wheels, former Maryland Governor's Commissioner of African Affairs.
Good afternoon, everyone. I'd just like to thank the Apache Foundation for giving me this opportunity. It's always a pleasure to work with Ms. Stella. And I'm the founder of Mercy International Medical Mission. It's an organization I just brought up. And I've been with community dentistry for a few years. And while with community dentistry, I had the opportunity, I was fortunate to represent the state of Maryland on the Commission on African Affairs, and I was the chair for the health. And during that time was when the Ebola crisis occurred. So I worked closely with Governor O'Malley then in finding how we could address the situation. Because when we talk about Africa or we talk about places other than the United States, we're all intertwined because we're global. We travel all around. And I also am proud to be a graduate of Howard University. So it's, I mean, I feel.
Is there anybody here who's not a graduate of Howard University?
You guys aren't? Oh, gosh, I still feel so sorry for you.
I'm thankful for the opportunity of having to have gone through Howard. And while I'm going through that, I would just like to, my approach is coming from being in the field. We have a lot of lectures, we have a lot of statistics, but I believe in being there, out there, touching and being with the people. Before I started that, community dentistry was founded, and how many of you remember that little boy, DeMonte Driver, that passed?
Yes.
Okay. It was rather unfortunate. He passed in February, and I launched my mobile van. That was when I became synonymous with the outreach, community dentistry, because of access. It was due to access of healthcare. Not that there wasn't a healthcare, but the lack of access. And that's what I think is very important when we talk about global. I was trying to kind of wait for that to come out, but I'll continue talking. So my topic is on the validity and the importance of medical missions for the underserved and underrepresented communities in bridging the gap, the cancer gap care. And our motto is saving lives by missions. I want to talk about the importance, the sustainability, and the challenges we face. Importance. I believe there's a saying that says, to whom much is given, much is expected. We that are here in the States, we're very blessed. We're very fortunate, and we're very lucky. And when we look out, not just to Africa, China, India, there are a lot of people that are impoverished and some don't have access to quality health care. And that's where I feel that my calling is to do whatever I can do, the little way I know I can do it. In dealing with the importance, I'm going to talk about health care. And the key thing is health disparities. And how do we address health disparities? By education and health promotion. I believe that we have to educate the public. Education, they always say knowledge is power. When you educate people and let them know what the importance of, I'm going to say brushing your teeth because by profession I'm a dentist. Just brushing your teeth, you may think, oh, there's nothing to it. But there's a lot to it. Because I view the eye as the eye is the window to the body. And when you brush your teeth, we not only look at dental diseases, we could tell you what is literally going on with your body. And I'm sure you would agree. We could see measles, we could see AIDS. A lot of diabetes can be detected by just looking at the mouth. That's why it's very important when the doctor says every 6 months, see your dentist. It's very, very critical. And that's why we have to educate people back home, wherever home is, apart from the United States. Even here, because I do a lot of health fairs here too. Education is very key. And a lot of these little kids, when we educate them, they go back home and educate their parents. And some of the parents are not educated, or they only have like primary 6 or high school. So it's important when we stress on education. And to me, by educating the public, we can help the government at the end in resources that will be lost. If you can say, the little boy that had died, may he rest in peace, if only they had had access and they had had education and he had been going to brush his teeth, seeing the dentist, he had a little tooth infection, which was an $80 extraction, would have cured it. They went ahead and did a $280,000 brain surgery because the infection spread to the brain. And he died after that. We never can say if he wouldn't have died, but at least we know that if he had been educated, gone to see the dentist regularly, that death could have been prevented. And because the families came to the ribbon cutting that I had, and the younger brother had the same situation. And a lot of this came through what? Nursing bottle caries. When we eat, sugar, they were talking about salt down there. Sugar is another big thing. When we eat, we don't brush our teeth. We don't teach the children that. Or the mothers put the bottles in the baby's mouth, the baby sleeps. What happens? That's a disaster waiting to happen down the line. So this is all about education. And the education now, I was focusing on dental, that has to also do with cancer, the breast screening. And in the African continent, there's a taboo about there's some things you don't talk about. And a lot of women, even men now, are dying because of, I can't talk about it. I've done a lot of medical missions, and so has the Patrick Foundation. And with these medical missions, what we find out is that because of the shame or the stigma that is placed in talking about your condition, you end up not doing anything. And those are the awareness we're trying to make sure that we get rid of. Breast cancer, oral cancer, diabetes and hypertension, nutrition, prenatal care, and STDs. The next one is access. And it's the lack of access that's the biggest problem when we go to African continent. MIMS is Mercy International Medical Mission, CDOW, the Patrick Foundation. What we try to do here is provide access to quality health care for the underserved and underrepresented communities. By doing that, we would attempt to meet the 2020 MDG goals. And we provide this by what? Education and screenings. By doing this, we eliminate and prevent diseases, thus improving the quality of life. We also do this by free donations. I've been very fortunate that companies such as Henry Schein, Brothers, Lions International, they've donated freely. And with these donations, I can inadvertently give it out to the community. And I'll talk about the challenges about later there. And we also do free treatments, surgeries, and cataract surgeries, hernia surgeries, cleft lip and palate, and cancer surgeries. So that's why it's very important, like I said, not only do we educate the community, but we also have to educate the government and the organizations abroad, because if they don't buy into it, they make it very challenging and very difficult for us to go the next step. The next topic I'll talk about is sustainability of the program. Funding is the biggest thing, and that's what I had asked when the government officials were there. But through public-private partnerships and also donations, it will make all what we're doing as when we do this outreach to make it much easier. Then the continuity of care. We don't just want to go into these communities and say, oh, we're here for 6 months and then leave. They have to be able to see that it's sustainable. No, they just come, they drop drugs on us, and then they walk away. What I do, I go back every 3 months. If we fill the prescription, in 3 months, they're going to get that prescription. But what good is it when I give you medication for high blood pressure and it runs out, and you're back to even worse situation than when I started treating. So what we do, we try to go back every 3 months or 6 months, at least every year. And what I also try to do is make sure that we use the community health workers and the doctors there so that the patients would know somebody to identify with, not just us coming from abroad. Volunteers, and that's where I was saying that we use the local indigents, and I also take some doctors. Community approval and acceptance. Because we make no money out of this, it's more of a passion thing. And when you see this, the patients pray for you and they just appreciate it, that makes you more motivated that I gotta keep this going. Right, Ms. Stella? Right. Challenges, lack of funding. Thus, we have to end up using our private money, or we have to go around sourcing from the community. The biggest challenges that I have faced is the shipment and clearance of medical supplies due to bribery. I have 2 40-foot containers right now sitting at my house, and I'm begging somebody to come and take it. I donated one to my church, Reed Temple, and for Haiti, we can't even get to Haiti. Because what ends up happening, they let it stay at the port, you stop paying demurrage, and then they just sell it, or they auction it out. So whoever can help us out to break through there is what that's the biggest challenge. Because the people back home, wherever home is, they want it and they need that. So, Madam Stella, please get us some people that will come next time so we can give them those things we want. And then government. If we can get the government to participate, prevention to me is better than cure, and they'll spend less money. Not just in Africa, even here, when we do these health cares. If you could just get communities or foundations like HHP to help us spread that word and educate the public. So we have to educate the public and provide screens and immunization. So the next slide, please. I will just go through quickly some of the missions I've done. And here's a patient. Doc, you may want to see this. The patient that, see, she had this for 7 years. She did not want to let it go. I even told her we had somebody that was going to do it for free pro bono. We tried to get her children to convince her. She said no, 7 years. The next line, yeah, see? And we have quite a few patients like this that because of the stigma or they're afraid or they don't know how they'll continue the care, they'd rather live with the disease. And then those were the organizers that I went with. That's one of my doctors. We have a mobile van. I also donated a mobile van to Nigeria. The De Monte one, I sent it to Nigeria, but this is not it. That's one of the doctors. We do extractions there. These are the patients. We see over 3,000, sometimes in a day, 3,000 patients. And like what doctor had said earlier downstairs, they're waiting. The patients are there waiting since 3 o'clock, 3 a.m. And we don't see them till about 8, 9. So I'm a stickler. If they can be there, there's nothing wrong in us being there, even though we're providing the services. So you can go on to the next one. And that's the king. What I usually do when we go on these missions, since the king is the ruling father of that area, I try to make sure that they're there. Because the community listens to them. So when they're there, they give that presence, our presence, greater value. And then I also, because I'm with Lions Club, I also do the vision. And then we donate free eyeglasses. Give them free eyeglasses. So they do vision care there. And then we do cataract surgeries also. So it's not just dental. I try to make it a holistic approach. So we're not just doing just dental. We're doing the whole body. Because you can't just take the mouth out. It's a whole system. Next one, please. The World Cancer Day, too, was done. And this was in another state. 0 minutes. Let me just go through it. Then that was the mobile van that was donated. And it's being used. You could just flip the slides. And then that's the medications that we donate. And then there's another there's another person that had cancer. You can go on. Look at her too. And finance usually affects them, that they can't get the treatment. So, and in closing, I would just like to say, please, whatever way that you can help us out, and remember, to whom much is given, much is expected. And I'd like to thank the Pacha Foundation, and I look forward to partnering with you guys again. Thank you. Thank you, sir.
Guess who's next? Dr. Minus is an adjunct professor of cancer causes and prevention at the University of the District of Columbia.
So my background, we should introduce ourselves. So I did my bachelor's in biochemistry in upstate New York, and I went and did my master in cancer biology prevention and control, and tumor biology. I did my PhD on tumor biology at Georgetown, and now I'm doing postdoctoral training at National Cancer Institute here in Bethesda. And my primary focus of research is actually health disparity research, especially on prostate and breast cancer, more on the biology side. So we see actually a difference in the biology, so we're trying to figure out what that is. But today I was asked to present on cervical cancer and the growing concern, especially in Africa, Latin America, and globally. Sorry. So I'm going to start by giving you guys some background, actually facts, to hopefully put emphasis on the problem and who the people that are affected with this problem. So cervical cancer is the most common cancer type in women in Eastern and Middle Africa. And in 2008 alone, 500,000 women were diagnosed with this disease. And 85% of those women were actually from the developing countries. And 9 out of the 10 cervical cancer deaths are from developing countries. These facts kind of put emphasis on the people that are affected with this disease the most. But there is some hope, especially from the lessons we learned from already developed countries, where the introduction of screening methods such as pap smear, for example, in the United States, led to a reduction in 75% actually. It's a huge reduction in incidence and mortality rates 50 years after the introduction of pap smear. And the fact that 50% of the women that are diagnosed with cervical cancer have never had pap smear done. I think that's mind-blowing to me, and also emphasizes the importance of this screening tool. And the remaining 10% haven't had cervical cancer screening in the past 5 years. So infrequent screening is also going to impact survival and diagnosis. So those, just emphasizing on those points. You can. So cervical cancer is the cancer of the cervix. So it starts from the cells that make up the lining of the cervix. So there are two different types: squamous cell carcinoma. Those are the cells, the long elongated cells that line the cervix, and also adenocarcinoma. Those cancers arise from cells that secretes the mucus in the cervix. So this is just an image on the bottom. You see that what normal cervix is supposed to look like versus a cancerous cervix. So this is a map showing the incidence rates of cervical cancer in 2012 worldwide. Just looking at it immediately, you can notice that there is a stark difference in incidence rate across regions around the world, where you see really very low incidence in North America and also Australia and Europe and some China countries. But you see that the highest incidence, so the darkest the blue, the higher the incidence. And you see these countries are the ones that have the highest incidence rates. So most of them in Africa, and there are also Latin American countries. This is mortality rates in 2012 worldwide. Once again, you see those countries that had the highest incidence rates also having the highest mortality rates. Again, a lot of countries in Africa and also in Latin America being affected the most by this disease. So just looking at this in the US alone, most of the cases that are diagnosed are actually localized. So 46% of the cases that are diagnosed are localized, where the survival rate, as indicated on the graph on the right, is 91%, so which is pretty good, 5-year survival rate. But versus if even in the US, if you were diagnosed, when you were diagnosed, the disease has already metastasized, so it has gone to a distant organ, then the survival is 17%. Still, even the most developed country doesn't have all the resources or the treatment regimens available to treat those diseases. And most, of course, you can imagine most developing countries, the women go to seek help, if they do anyways, when they develop symptoms, which is already, it's too late. Most of the time, by the time they develop the symptoms, they have already, the disease have already metastasized. So this is the survival rates that they're facing, which wouldn't matter anyways, even if they are in developing countries. So the key is really doing better in screening it so we get it at a much earlier stage. So the variability in incidence rate and mortality rates we see globally is also, it's not just limited globally. We see it in the US, where different racial groups are actually suffering disproportionate incidence and mortality rates from this disease, where we see, of course, blacks suffering highest mortality across compared to other racial groups. Really, I think poverty is the big contributor for this, especially for this disease, not for all cancer types, but especially for this disease. If you look at this is a graph showing, for example, if you look at the HPV-associated cancers of vulva, vagina, anus, head and neck, you see that poverty doesn't really influence the rates. Whereas if you look at the cancer of the cervix, you see that the lowest the poverty rate, the lowest the poverty level, the lowest the cancer rates. And then the highest the poverty level, you see a higher cancer rate. So this is probably because there's already a very effective screening method test that is available, and those who have the higher socioeconomic status are more educated and have access to these versus those that are not so, that have low socioeconomic status. So the impact of really nationwide screening program is also reflected by the introduction of this screening program in the UK, where you can see the blue line is when in 1988 when screening program was introduced in the UK. So following that, you see a huge decline in incidence rates. So that kind of shows, kind of gives evidence for introducing such nationwide programs in these countries where they don't have one. So really, like I mentioned earlier, screening is really the key because we want to get the disease before it's cancerous. So the screening methods available help us to do that. So we can detect them at the pre-cancer stage where there are effective treatments available. So the screening methods available include the conventional pap smear that we all know about, but there's also HPV DNA testing. So both of these require that the cells are taken from the cervix and then they are sent to the lab and they are tested for that. So which takes time and is costly. But they're effective and especially combined they have been shown to be effective. The least, I guess, costly one is the visual inspection with acetic acid, which is VIA, which I think now is being used in less developed countries. So just because they basically apply acetic acid in the cervix and they wait right there to see if there's a color change. And then they are able to give diagnosis immediately while the practitioner is doing the procedure. So it's cost effective, but there are, of course, issues with sensitivity and specificity. So maybe a combination of these tests at different time interval may be the right strategy for countries like Africa. Continents like Africa. This is just to give you guys an idea of the cost. So pap smear, this is from South Africa. So telling you, pap smear costs $8 per test. The acetic acid test costs $3 per test. Whereas the costly one, which is HPV DNA test, costs $54, which gives you kind of, which these costs will be, of course, relevant for poor countries. I'll just quickly go through. So this is basically to tell you guys that if we don't do nothing, the incidence rates, if they remain the same, actually the new cases are expected to double of cervical cancer in most countries by 2030. So we really need to do something about that. So I see this as a field opportunity to grab, because cervical cancer is one of the most preventable cancer types, and the fact that we still have countries, we still have this disease being the most common cause of cancer death, and in some countries, it just breaks my heart. We have to do better, and some of the problems I think is lack of knowledge, of course, awareness about the disease. I've done outreach even here in the immigrant population, and there's like zero awareness about the disease, let alone the screening method. So, of course, the infrastructure, the healthcare professionals, all of this is going to be relevant. Where in a country where I'm from, where you have like 4 oncologists for the entire country, how feasible is that? So we need to train more people. So, questions?
Do we have time for a couple of questions? Okay, then we do have time for a couple of questions. First, let me thank you for the presentations. Excellent. Very informative. In particular, yours is, you use the term passion. It's a passion of mine, international health. Actually, I'm formally trained in that also, public health and international health. A couple of comments, but let's hear your question first.
Yes.
So with our medical missions, we do the BIA,
VIA, okay,
Yes,
that's good.
VIA with cryotherapy.
Okay,
And
that's
I
good,
think Last year we started coag as well, coag therapy.
Okay.
So my question is, we have an internal struggle going on with our screeners because I think that WHO is moving away from
VIA? Oh, okay.
and they're recommending HPV testing
Okay.
plus plus a
Pap smear, yeah, the combination.
which is really not feasible at
For
all
Africa.
in a medical clinician setting, or even in a country like where I am from. So I just wanted to pick your
Yeah.
brains on that about why
Yeah.
we would be making that distinction between the two. Is
Yeah.
one more effective than the other in diagnosing?
Yeah, I think it's obviously the even HPV alone, testing alone, or Pap smear alone is not as effective, but in combination it's effective. So that's why they're trying to recommend. But I believe really, and I don't think we should copy paste everything, the screening guideline that people use in developed countries to Africa, because it may not be the most feasible, right? So I think what has to happen is basically to develop a new screening guideline for that community, whether it is to do those Pap smear tests, but not as frequently as they recommend here. But in between, you would follow up with the VIA, So to have like kind of a different strategy than just following, because it's not going to be feasible. So the choice we have is we have to decide, and those, if we have those kind of strategies, then we can test it how effective we are. So we should have actually research that is being done to actually test the efficacy of any strategies we use in those scenarios.
Any other questions? Well, just a comment on yours, because that's my most current and recent. Started as a passion and now it's an activity. So, you made, I think, 3 points that need emphasizing, and my opinion at this point, I happen to be writing a couple of papers on them actually, arise from a long experience in the field. First, you got to have the passion, which I've commented on. In the developing world, effectiveness, in my opinion, maximum effectiveness involves getting involved with the government, the Ministry of Health. In the developing world, the government is responsible for most health. It's not like here. See, it's not market-based health care or anything like that. It's public health, now emerging from communicable diseases to chronic diseases, okay? So that it's important to involve the government. The third thing, the goal being the third item, sustainability. Sustainability does not mean, in this context, going there frequently for 10 years and so forth. Sustainability is what you leave behind and what effect it has on that population in the context of the goals you're trying. That can involve a number of things. It's been mentioned from our end, the PPP, the public-private partnerships, and a lot of other things. Fortunately, we're in a position now, or we were until Trump, where there's a sense of global involvement, and you could get our domestic people involved and so forth. And I think that's the domestic effort that goes into this sort of thing. Yeah, but I'm going to end there. As you can tell, it's a passion of mine. I've done this all around the world, actually developed and developing countries. In China, where they were trying to, some provinces trying to evolve from public-dominated healthcare into experiments with private or not-for-profit healthcare. been over there and advised in that. So, you know, until Trump came in, and I say that because I'm not sure what it stands for.
I know,
frankly.
that's what's scary now.
Yeah.
That's what's scary right now,
Huh?
yeah.
Say that again?
Let's hope he surprises us.
How can
It'll
he
be a surprise.
Listen, he speaks on
It'll
both
be a
sides of
surprise.
every issue. He can't surprise you. We don't want to get political.
And that's one of my concerns right now when I was talking to Ms. Stella. And that's why I think that we, as because we're so concerned and we're so engaged in our different professions, we really need to collaborate together because we cannot wait for what any government's going to do. Because right now, I'm telling everybody that whatever I can ship, whatever country wants it, let's do it because it's going to stop. Because remember, I used to get a lot of grants and things, but when big organizations started coming on, like I'm going to use an example, my school, HU, when they come on, you know, a lot of these things, they do it for like photo op and whatnot. So little organizations like us crumble. And once that happens, they're gone.
Yeah.
And if we're not
Never-
careful,
never
there's
comes
not going to
back.
be anything. Even that's what I'm talking about locally and internationally. So if we don't step up instead, yes, the government's not going to do anything in any country. Let's be realistic about it. But we have to just find ways and means, and people that are as passionate, we just have to collaborate together. I think that's going to be the solution.
One last caution it is important that you export knowledge, skills, and so forth from here. But you've got to adopt those to the models there. There is always the danger of trying to export tertiary high-tech stuff there
No, basic ones.
into countries that can't either afford or absorb it.
That's why you
So
work
you've
with
got
them.
to be very precisely.
Yes, you have to work.
Yes.
And you always have to work with the community. When we go, we talk with the community healthcare workers there. So they are part of the mission.
Oh, they have?
Yes.
Because the people trust them. They know them. They don't know us. So it's like, you just can't come in. And if you're using a chewing stick to brush your teeth, I'll just show you how to use it more effectively. Because I want to be realistic. Not everybody can afford a toothbrush.
Right.
So if it's a
Right.
chewing stick you're using and it's working, just use it and let them check it out. So you have to work with the community you're in.
Okay.
Guess that's it.
I'm seeing a signal out to the corner of my eye. And thank you again for coming.
Very good.
Yeah.
I'll be in touch.
Yes.
I got to run now too.
No, I didn't. No. When did you come out of Howard?
2001.
Okay. But, you know, if you've ever done an NDA or if you do have
Yeah, I
stuff,
did. Yes.
well, like I said, I'm a past president. People seem to know my face.
Yeah,
from that.
probably that's what it was.
And at one time, again, I was up to 2 years ago, I was the interim executive director of the NDA.
Okay, that's what. Yeah.
So
that's
you'd see my face a few times, you know, related.
Please, if you want me to come
Sure, I got your call. I got your
Yeah.
call. See what you're
This is my
doing.
husband. Well, he's the
Congratulations
financial-
on all that you do.
I'm trying.
How are you, sir? I'm fine. How are you?
Thank you.
Very good.
Because I bled his all his money.
Well, I know. I looked at him. I saw that CPA on there. So he knows how to handle the money. We know that. He knows he should be making that money.
So I'm learning.
Hi, Dr. Answala. You know, I always enjoy hearing. I know you. Yeah, this is excellent. Excellent. Now, I was glad to hear about all your good work on the cervical cancer. What brought the information as well.
Keep up the work.
Thank you.
You know we need it.
Yeah, I have a business card, you know.
Unfortunately, I didn't print one, but